In this lab, we have 3 clinical cases of different neoplastic conditions. First case is about a 20-year-old female patient with a round mobile breast lump, and she has no family history of breast cancer. First thing in approaching a patient with breast lump is history taking, focusing on risk factors as gender, age, family history, and others. Second thing is a clinical examination of breast and axilla. Next, doctor might order imaging studies as ultrasound and mammogram or histopathological examination. The definite diagnostic test is histopathological examination of biopsy. For breast masses, biopsy is usually done by FNA or core needle biopsy. FNA is a procedure done using a thin hollow needle that is inserted into the mass to obtain samples. In this case, the most likely diagnosis is fibroadenoma. It's the most common benign neoplasm of female breast. It's a biphasic tumor composed of fibroblastic stroma and epithelium-lined glands. Fibroadenoma typically appears in young women as solid discrete mobile mass. It enlarges slowly over time and regresses after menopause. Fibroadenoma is a biphasic tumor, therefore it's an example of a mixed tumor. This is the gross appearance of fibroadenoma after surgical excision. It's a well-circumscribed mass that is firm and rubbery on physical examination. This is the microscopic appearance of fibroadenoma. It's composed of fibroblastic stroma in which are located compressed ducts lined by benign-appearing epithelium. Fibroadenoma is a benign tumor and the malignant change is extremely rare. Compared to the malignant growth, the benign growth is usually well circumscribed, slowly growing, well differentiated, and does not metastasize. Second case is a 30-year-old female with a hard breast mass of several months duration, and she has a strong family history of breast cancer. First question is what genetic abnormality may be found in this patient? In inherited breast cancer, we have 2 types of genes, BRCA1 and BRCA2. They are dominant genes and may cause breast and ovarian cancer. In familial breast cancer, patients usually have family history of breast cancer, but not strong. What investigations are recommended in this patient? As we said before, imaging studies as ultrasound and mammography, FNA or needle core biopsy. This mammogram demonstrates a mass lesion that was a carcinoma on FNA cytologic examination. This is a FNA cytology. On the left, at low magnification, discohesive cluster of cells are seen. On the right, at higher magnification, the typical nuclei characteristic for a carcinoma, high nuclear pleomorphism and high number of mitotic figures are present. In this FNA cytology, we can see discohesive cells with marked nuclear pleomorphism. The diagnosis of previous FNA cytology is cellular smear with pleomorphic cells that are mostly malignant. This patient underwent surgery for a frozen section and wide excision or mastectomy. What is frozen section? It's a technique to perform a rapid microscopic analysis of the specimen to provide immediate report. The sample is processed by cooling or freezing rather than paraffin section. Here is a gross appearance of a breast cancer. The mass is irregular and the center is very firm and white. This is because of dysplasia, which is the marked increase in the fibrous stroma. Such tumors appears hard and non-mobile on physical exam. The tumor was very hard and gritty on cutting. This is because of dysplasia. This microscopic section of breast cancer shows small nests and infiltrating strands of neoplastic cells with bands of collagen between them. This is the dysplasia that produced the characteristic hard appearance of the ductal breast carcinoma. The patient also had several enlarged axillary lymph nodes and mass in the lung. This is most likely metastatic ductal carcinoma of breast origin. Here we see neoplastic cells in the dilated lymphatic channels. This is the gross appearance of a lymph node involved by metastatic ductal carcinoma. Metastases produce firm painless enlargement of the lymph nodes. Seen here are neoplastic glandular configurations representing metastatic adenocarcinoma. Here we see metastatic breast adenocarcinoma in the lung. In this slide, a focus of metastatic carcinoma from breast is seen on the pleural surface of the lung. Such metastases may lead to pleural effusions. Apart from confirming diagnoses, microscopic slides can be stained with immunohistochemical stains to guide the treating physician in therapy and to assess prognosis. In breast adenocarcinoma, the stains that are used for these purposes are estrogen receptor, progesterone receptor, and HER2/neu receptor. These tumor cells in nuclei stained positive for estrogen receptor stain. These cells have membranous positivity for HER2/neu receptor stain. HER2/neu receptor is the human epidermal growth factor receptor 2. It's overexpressed in many high-grade cancers, which may be treated by anti-HER2/neu. Third case is a 28-year-old male patient complained of nausea, vomiting, abdominal pain, and bloody stool. His uncle and grandfather died of colon cancer. On physical examination, his liver was enlarged. Investigations include chest X-ray, abdominal ultrasound, and colonoscopy. The results were multiple bilateral lung opacities in chest X-ray, multiple liver nodules on abdominal ultrasound, and the colonoscopy showed hundreds of polyps in the colon and an ulcerating mass in the sigmoid. The colonoscopy suggests that the patient has familial adenomatosis polyposis (FAP). With the findings of chest X-ray and ultrasound, he most likely have a malignant colon tumor arising from one of the polyps with metastasis to liver and lung. Familial adenomatosis polyposis is an autosomal dominant disorder characterized by early onset of hundreds to thousands of colon polyps. If left untreated, all patients with FAP will develop eventually colon cancer. The genetic defect in FAP is a germline mutation in one copy of APC gene, followed by other several steps. Patients with FAP may develop also duodenal adenocarcinoma, desmoid tumor, and other tumors. This slide shows the molecular pathway that leads to the colonic carcinoma in FAP. It starts with a mutation or loss of one normal copy of the APC gene. This first hit mutation can be inherited or may happen later in life. The second hit is loss of the second copy of APC gene. Other changes will follow, as a mutation of KRAS and others. This will lead to emergence of carcinoma. This is familial adenomatosis polyposis in a patient who had APC gene. The mucosal surface of the colon is a carpet of small polyps. The inheritance in FAB occur in an autosomal dominant fashion, and the risk of development of adenocarcinoma is 100% without treatment. So, total colectomy is usually done before age of 20. This is a small tubular adenomatous polyp on a small stalk, having more crowded and disorganized glands than the normal underlying colonic mucosa. Goblet cells are less numerous, and the cells lining the glands of the polyp have hyperchromatic nuclei. These are the features of dysplasia. However, it's still well differentiated and circumscribed. So this is a polyp of low-grade dysplasia. Here is another example of dysplastic polyp. What are the features of dysplasia? Increased ANSI ratio, pleomorphism, loss of differentiating features, hyperchromatism, prominent, sometimes multiple nucleoli, increased mitotic figures, presence of abnormal mitosis, loss of polarity in an epithelial surface. This is the gross appearance of a colon adenocarcinoma and a large adjacent polyp. This is adenocarcinoma of the colon at ascending colon. Staging of colonic adenocarcinoma is based on the degree of invasion into and through the wall. Microscopically, an adenocarcinoma of the colon is seen here. The neoplastic glands have crowded nuclei with hyperchromatism and pleomorphism. No normal goblet cells are seen, which is loss of differentiation. This slide shows adenocarcinoma with wall invasion. As you can see, the malignant glands reaching deep in the colonic wall. This is a metastatic colorectal carcinoma in the liver. Note the numerous mass lesions that are of variable size. Some of the large ones demonstrate central necrosis. The obstruction from such masses may elevate alkaline phosphatase, but not all bile ducts are obstructed, so hyperbilirubinemia is typically not present. The transaminases are usually not greatly elevated. Here is the liver with metastatic adenocarcinoma. Note the serrated edges of the metastasis and the prominent central necrosis seen in the large nodules. Of all neoplasms involving the liver, metastases are the most common, because the liver is a good place for neoplastic cells to grow. Metastases are usually multiple throughout the liver. Microscopically, metastatic adenocarcinoma of the colon is seen here. Seen here are neoplastic glandular configurations in a lymph node representing a metastatic adenocarcinoma. Seen here is a transcoelomic spread of colon cancer along peritoneum. Transcoelomic means in peritoneum. So transcoelomic spread refers to the dissemination of malignant tumor cells throughout the surfaces and organs in the abdominal and pelvic cavity covered by peritoneum. Another inherited colon carcinoma is hereditary non-polyposis colonic carcinoma. The molecular defect is in a DNA mismatch repair gene. Mechanisms of cancer spread are direct invasion, when the tumor grows and locally invades the adjacent structures. Lymphatic spread refers to when cancerous cells enter to lymph nodes and vessels. Hematogenous spread when cancer cells enter into the bloodstream and spread to the other to other distant parts of the body, and transcoelomic spread. Stage is the extent of spread of the tumor. The most used system for staging cancers is the TNM system. Physicians may need to use many tests and radiological studies to assess the extent of tumor spread. Staging is important to determine the best method of treatment and to assess the prognosis of the tumor. This diagram shows the TNM staging system of lung cancer. The T indicates primary tumor size and extension. The N indicates lymph node involvement, and the M indicates distant mets presence. As we said before, staging is important to determine the best method of treatment and to assess the prognosis of the tumor. Many tumors may show widespread metastases. These include small cell carcinoma of the lung, melanoma, and osteosarcoma. These are benign nevi. They are small, usually less than 1 cm in diameter, brown in color, and flat to slightly raised. A malignant melanoma of the skin is shown here. The lesion is larger than a centimeter, has irregular borders and irregular pigmentation. The prognosis of melanoma correlates best with the depth of invasion. Larger lesions are more likely to have invaded further. Here are multiple metastases of malignant melanoma, darkly pigmented from the melanin in the tumor cell cytoplasm. This is an osteosarcoma of bone. The tumor mostly occurs in young patients. The tumor usually arises in metaphyseal region of lung bones. This is a chest X-ray showing multiple bilateral lung opacities representing lung metastases.